We are on a mission to save and revitalize independent pharmacy. On the Catalyst podcast, we dive into current events that are shaping how pharmacists approach their patients and their businesses. Fuel your passion for pharmacy, one conversation at a time.
3, 2, 1, 0. Ignition.
Welcome to the Catalyst Pharmacy Podcast. I am Mark Bivins, Vice President of Business Development at Pioneer Rx. Today, I am here with my co-host, Josh.
I'm Josh Howland, Vice President of Clinical Strategy at Pioneer Rx.
And we have Ben Jolley here from Jolley's Compounding Pharmacy in Salt Lake City, Utah. He's probably one of the, at least from the social media side for sure, like very present on social media, but also like a contracting sell-side strategy expert.
I'm a third-generation pharmacist. My grandpa got into pharmacy in the 50s and started the family business on June 7th, 1954. Then my pops joined the business. He graduated pharmacy school in 1980. And then I started working in the pharmacy when I was 14 years old as a clerk. That was when I started working there. I have I'll share an amusing anecdote from
All right.
when I was in that.
We love those.
So I think I must have been 6 or something. And I was at the time, my family, my dad and his brothers owned 3 pharmacies jointly. They've since split ways. But anyway, so I was at the other store that's now my uncle's solely. And they were doing some kind of meeting or something. And I was just in the back at the ordering computer, which for some reason they had a computer that's like solely dedicated to that.
They used to do that a lot, like way back. You'd have like one green screen computer that you walk by and like order every now and then. It was weird.
Yeah, it was just the ordering computer in the corner. And so they left me just on a chair there. I remember it was a raised chair, like, I'm like probably 3 feet tall, and it's like raising me up like 3 feet or something. And I'm just sitting there looking at the computer, and the ordering website was pulled up, and I discovered that if I pressed like buy now or order, it would do this really cool like 1990s graphic where it would send, it would show this picture of an order like, I don't know, like flying over to the wholesaler or something.
Oh, that's so good.
And so I think I must have ordered like $20,000 worth of product that day that they did not need.
God.
So my uncle discovered what I had been doing and was just like, what the heck? Because I had just been pressing this button because I'm like, this is a cool graphic. I'll just watch this over and over again.
I love this. It's a game, right? Yeah. No doubt.
Those are some of my earliest memories in the pharmacy.
So that was Benjamin like first getting into the buy side of the business when he was
there you go, just
old.
clicking buttons for
the
fun
buy
to
side's
watch
easy.
things.
Right. Apparently, yeah. 6-year-old could do it.
Not correctly and can order a lot more drug than you need before they had agreements where you could return stuff with full credit. So, yeah, so I started working in the pharmacy when I was 14 and then got my tech license or started doing deliveries when I was 16. I was our driver. I went and I would visit this one old lady, I remember, who could not lift her arm above about here, like, I don't know, 70-degree angle.
I have that same problem, actually.
And so I would deliver her hydrocodone every month. And she would always, every month, I would go deliver her meds, and she would sit there and talk to me for like 10 minutes while she used her very disabled arm to check.
Yep.
And then would hand me a $5 tip every time.
That's cool.
From there, I got my technician license when I was 18, and then I remember. So I'm LDS, and I went on a mission to Italy, and as I was finishing that, my mission president, the older gentleman who's like in charge of all the missionaries, um, he gave me an exit interview, and as we were talking, he told me that I needed to think about a career, and he gave me some criteria of like what a good career looks like. He said you need to have a career where you enjoy your work. So it's one where you're not going to wake up in the morning, look at your wife, and say, "If I didn't have a wife, I wouldn't have to go to work. I hate work."
If you didn't
Right.
have a, that's sage advice.
That was, he had three criteria. That was one. Two is one that pays well enough that you don't have to work like 80 hours, 100 hours a week. So you have time to help other people and give back. And then the third was, God, I can't remember the third. Whatever.
Those were the two that were good ones.
No, the interesting part about that is you still chose pharmacy.
Right. So as I was sitting there, 21 years old, I'm sitting there. Well, my dad makes a decent amount of money. That's a job where you don't have to work like a bazillion hours.
Right.
I mean, usually he works 40 and 50-hour weeks, but he's not usually working 100-hour weeks. So yeah, okay.
Where did you go on your LDS mission?
Milan, Italy.
Oh, wow.
I mean,
Yeah.
there are some worse places
There are
to
worse
go.
places to go. Yes. Yeah.
There are definitely worse places to go. I definitely drew the long end of the stick on that one.
Are you fluent? Are you fluent in? Is it Italian? I'm assuming, right?
Yes.
Josh is looking at me like I'm an idiot.
People
Yes,
in
Mark.
Italy
Yes,
do
Mark,
speak
it's
Italian.
Gotcha.
Ho studiato anche in università.
But let's just do it
yeah.
like this. Let's just do the rest.
We'll just have to true and believe that you're actually speaking Italian.
Right. He's just insulting us the whole time. Are you fluent in any other languages? I think you are.
I mean, I speak some Spanish, but I would hardly call myself fluent in
Gotcha.
Spanish. I mean, it's close enough to Italian that I can, as they say in Italian, me la cavo. I can fake it,
You can fake it. Cool.
which is a lot more useful than speaking Italian here in Salt Lake. No one.
Yeah. It's probably,
I've had, in the last 3 years that I've been here, I've had one person come in from Italy, and so I got to talk to him. But I've had
cool.
like 200 people who are Hispanic who don't speak any English. So
Yeah. You're probably his pharmacist for life, though. I'll tell you that.
he went back to Italy after.
Okay. Sorry.
So a really good,
It's a good
strong
setup.
interaction. Yeah.
Yes. I convinced him that America was not for him.
Clearly. He's like, you know what? I'm out of here. I think you were one of the folks publicly, at least out there, kind of talking about it. I think we're going no PSAO, for people who don't know what that is, Pharmacy Services Administrative Organization, helps with contracting with the PBMs. And you guys were like, you know what? I think we're going to elect to not do that and see if we can manage it ourselves. Can you give us a quick update on how that's gone? I think it's been, 10, 11 months now.
Yeah. So last year we were looking at the numbers, and basically since late 2018, I've been thinking about this because I just heard of all these pharmacies getting hit with these massive true-ups due to generic effective rates. And I was like, I don't want to have a $50,000 true-up just randomly come out at us. And I discovered that if you were not part of a chain or a PSAO, then, to my knowledge at least, there's no generic effective rates in any contract with just a single pharmacy entity. And so, yeah, we decided to contract on our own. And so I am the PSAO here at our pharmacy. I provide all of the credentialing and all of the services that they provide. I do them here. And it's been interesting. So, I mean, there's been some really I mean, I've enjoyed it because like I get to actually be the one who decides, do we take this contract or not, right? Rather than delegating it to a board of people who may or may not have the same strategy as me, right? Because PSAOs, their main purpose, like with their founding in the 80s, was to gain access to limited access contracts because being able to contract with, a 5,000 store entity with one signature from a PBM's perspective is much easier than signing 5,000 individual pharmacies. If they want to design a limited network, they're going to go with the easier route. But recently, these limited contracts are just, I mean, I don't know anyone who really wants to take them because, I mean, you want to be able to service your patients, but the reimbursements are just so poor that unless you are a Walgreens or a CVS where you can buy drugs for a tenth of what I do or something, I don't know what they have the capacity to buy at, but unless you have that ability to buy much more aggressively, then those contracts are just a sure loser.
So in terms of payer mix, in some states, not being in like say a prime network would be devastating. Do you guys have like a real, like, I guess a more
balanced?
Yeah,
mix?
Balanced is a good word. Like a payer mix.
Diversified
in
kind
Utah.
of?
Yeah, it is diversified would be better. Because like, you take like North Carolina and it's Blue Cross.
Right. Same with Louisiana, right?
Right.
Losing that contract accounted for about 11% of our fill volume. So,
wow.
But to be frank, it wasn't terribly high margin business. So we lost a lot of volume, but we didn't really lose a lot of margin. If you're a rural pharmacy where there's like no pharmacy for 30 or 50 miles, you have a lot more leverage with PBMs. And if you're in that situation and you're with a PSAO, you should strongly consider
bold.
direct contracting because you can get substantially better rates than what your PSAO could get.
Wow.
I mean, I've talked to some folks in rural areas, and they're getting. I would not be worried about our margin if I had their contracts. Let's just say.
Wow, that's interesting. What about like administrative burden, just in general? Like, that's kind of one, I guess, convenience factor of a PSAO. Is it kind of an administrative nightmare? Is it seasonal? Is it kind of like, hey, you got to kind of grind it out for a couple of months and you're kind of done, and you build your metrics or you build your dashboard or you build your whatever to monitor what you agreed to. But is it an all year kind of,
slog?
Yeah.
So most of the work is up front.
Okay.
I mean, doing the credentialing with all the PBMs takes a substantial amount of time, and I figure it took us probably 40 or 50 hours to fill out all the paperwork for all of the different PBMs that we're credentialed with. But then like the maintenance bit, I mean, I don't really feel like it's much better or worse than it was before. It's about the same. I mean, even when you're with the PSAO, you still have to update your NCPDP profile. Right. And that's a lot of the maintenance work is just when you get a new liability policy, you put it up on NCPDP. And like if you're contracted on your own, you have to remind yourself to do that. Right. Right. Where if you're with the PSAO, they'll send you nasty grams if you don't do it. But you still are the one doing it.
Yeah, right. That helps.
Yeah, I mean, if it weren't for nasty grams, I probably wouldn't do a lot of stuff.
Basically, you're still the one doing the work of uploading the stuff to NCPDP and making sure that your fraud, waste, and abuse checks are done and making sure your staff is HIPAA trained. I mean, the PSAOs will provide tools to make that easier than if you're doing it by yourself. But like, I mean, you still, it's not really a different level of work. It's just a different level of paying attention.
I gotcha.
Right. Versus someone paying attention for you.
Right.
As far as like throughout the year, I mean, we've been getting contracts for 2021 all year long.
That's where I was going with that. Yeah, I think you're getting some more information a little earlier, I think, right?
Yeah. So like we got some contracts starting in like April for 2021.
Wow.
of like, do you want to participate in this network or that network? And so, and they say like, you have to respond within like 3 or 4 weeks or something. But then if you don't respond, they send you another one a month later with notice 2. You must respond within 3 or 4 weeks. And I think that for one network, I think WellCare, Caremark sent me 5 notices.
See, Josh, you're still getting your nasty grams. Yeah. You're still getting your nasty grams.
Not the same kinds, but yeah.
Right.
And so it's just like, do you want to participate in this network or not? But yeah, we've known since April what the DIR fees are going to be for 2021 for that network and what the contracted rates are going to be. And so we turned that contract down. So anyway, it's been really interesting because like, yeah, I see all of this stuff all year long, and then some other folks are like, how do you know what your DIR fees are going to be a year, like almost a year in advance? Well, they send you the contract for review all the way back there because like they need their network to be in place by like July, so that they can have everything in place for CMS for open enrollment in October. And so since you don't have a PSAO, you're the one that evaluates the contract, where the PSAO gets that contract the same time as I do in April, then they evaluate it. And then in October, you find out what they agreed to on your behalf.
Right. Okay.
That's interesting. Yeah. There's a lot of transparency that's lost in that process.
They do have some negotiating leverage to push back, right? Because they've got, a couple thousand pharmacies to say, hey, I don't like this section of this agreement or that section of that agreement, but where I have zero leverage whatsoever. That's
true.
I take what they give me and
decide,
and that's it.
Right. Yeah. Decide to take it or not.
With level funding and self-funding, I mean, you can do a lot more with your benefit. Like pharmacies, so pharmacies that are fully insured and then have their employees run their prescriptions through their health insurance, are basically paying their premium, and like the portion of the premium that's attributable to the drugs they're purchasing is probably like 5 times the acquisition cost of those drugs.
Right. Right.
And so pharmacy would be much better off to financially to just basically just say, you get drugs for free at our pharmacy, or you pay a $10, like
up to
just
a
pay the
point
pharmacy a copay, rather than using the insurance and then like seeing, oh, we made $20 on this prescription. You didn't make any money on the prescription.
Right.
You're paying for it, right?
Yeah, it's in your premiums for sure.
And so, anyway, so the pharmacy, like just capturing the cost of their prescription benefit inside of the pharmacy rather than sending it off to a third party and then paying it through the premium is like, it's really silly. Like I love the analogy that people give of like purchasing drugs through insurance is like, most of your cheap generics, right? Purchasing lisinopril through insurance is like purchasing your gas through Geico. The administrative burden of doing that just means that Geico is going to increase the net cost. Like the cost that you see at the pump might be 20 cents a gallon, but what you're paying in your premiums is going to be substantially more.
Right.
So one of the things I was going to, like, we could probably talk about insurance all day and nerd out on that. So I know you're involved with Flip the Pharmacy, and a lot of what Flip the Pharmacy is geared to do is really help some of those pharmacies go from kind of operationally, I count by fives, drop pills in a bottle and run away, to really kind of becoming the next step of a clinical service. Can you kind of describe what you've been doing in your area of Flip the Pharmacy?
Yeah. So I am the team lead for Team Utah with Flip the Pharmacy. We've got 19 stores that are participating. Something like half of them are Pioneer stores. The other half use variety of vendors. So what we're So last night I was down in Utah Valley visiting 3 other pharmacies that are participating. And so I coached them on this month's change package, which for Flip the Pharmacy, like these are not secret. You can find them online. Even if you're not participating, you can follow along with Flip the Pharmacy.
Okay.
I mean, it's all on flipthepharmacy.com. There's no secrets here. The concept is to flip the entire industry's model, not just the 500 stores that are participating, right?
Right.
And so anyway, so last night I went down to these 3 stores and went through this month's change package, which is just basically saying, hey, as you're checking people's prescriptions, go and check also their immunization registry. Like each state has their immunization registry that shows what immunizations each person's gotten. So go and check the registry for folks and see if they've gotten their shingles shot and their pneumonia shot and their tetanus shot and their flu shot. And if they haven't, talk to them about it and give it to them. Right. And then the thing that Flip the Pharmacy does differently than prior models like this is that we document what we're doing in the pharmacist's e-care plan. And then that gives us in the aggregate across these hundreds of pharmacies that are participating, that gives us like some population health level information of like, look, these pharmacies are intervening hundreds of thousands of times, and they're doing this kind of intervention at all of these different places. And so like previous grants and stuff like this have like shown that, you know, if a pharmacy is like the Asheville project, if a pharmacy is involved in caring for patients with diabetes and high blood pressure and is like involved in the care team and is incentivized to do so, they can drop the total cost of care for employers by just this enormous amount.
Right.
Like we're talking like, I think something like 80% of people in the Asheville project saw their A1Cs drop, and by every visit the A1C was going down. Like that's unheard of kind of results. But that was like 20 years ago, and pharmacists still aren't doing that. And it's because it didn't scale easily. Where what Flip the Pharmacy is trying to do is just, we know these things work. We just want to implement them at scale in pharmacies across the country, and then make sure that the pharmacies are documenting it in a structured format that's legible to payers so that they can see the benefits of what we're doing without having to do a lot of manual data gathering.
Right. And what you said there is really key, of the structured piece, right? That's where one of those areas where it's been this big gap. And, you know, I always point to email as being kind of your gold standard of that. You can send an email across the planet, and it doesn't matter what continent you're on, what language you speak, the structure is the same, and you can read it, you can do whatever you want to with it. And healthcare data has been historically terrible at that. And the eCare plan allows you, you know, we're sending things by ICD-10 codes and SNOMED codes and LINC codes. And all that just means on the end is a pharmacist can share that with literally anybody and speak the same language. Yeah.
Yeah. One of the really cool things is that the eCare plan is on FHIR, right? The Fast Healthcare Interoperability Response. So that means that any other system that any other system that uses FHIR can just take components of the care plan and suck it into the appropriate section of their EHR or of their whatever the insurance companies use as their databases. But FHIR is a growing industry standard, and so since this is like each of the segments is written in FHIR, they can just suck out the appropriate elements into the appropriate elements of their chart, basically. And so you can share information so much more easily than you could, 20 years ago.
Right. And one of the things that we recently did that I know you're excited about, because I got the issue that you submitted that we did it off of, like one of the things that we've constantly seen change is now when the new e-prescription standard, you can send over a ton of information. And part of that was vital signs, right? So now you can get height, weight, blood pressure. So we recently pulled that into Pioneer as a whole, and that then automatically gets added to the e-care plan. Right. So you see this constant feedback loop of being able to consume and share information in a way that would have taken, a couple of faxes, maybe a phone call before to get that information that's now just there.
Mm-hmm. Yeah, I was really pleased when I was visiting a pharmacy last night. They had no idea what I was talking about when I said that vital signs were there, but when I asked them to pull up a patient chart and look in the labs tab, sure enough, there it was. Because this is a Pioneer store, and so they had like 6 months trending data of the patient's weight and height, which the height's hopefully it doesn't really have a trend.
Yeah.
If there's a different problem.
They tend to trend up in young people and down in older people.
Right. Okay. Noted.
Yeah, but not over 6 months usually, at least in older people.
That's true.
Unless you had some kind of very traumatic event, you'd see a pretty quick trend there.
Yeah, it's probably a quicker trend.
Well, it's funny. And my grandma was a diabetic before she died a few years ago, and she was really excited because she called and she said, "I lost 50 pounds," and I was like, "That's great." She had a below the knee amputation, I was like, "Oh, come on."
She's funny. All right, I love her. So in the what's in it for me here, like this is gonna be this. Treat me like a dumb person for a second. Well, not that you don't already, Josh. So I hear Flip the Pharmacy. I'm not as involved with it as Josh is. Clearly in our company, is a little bit of it is. I know it's a grant program, correct? Right. And it's let's demonstrate in a scaled way, like Benjamin said, the impact we're having. And that's kind of like the ultimate white paper to go hang around and show to health plans or project, whatever, like the results of this is kind of like the ultimate white paper presentation to go, you need to spend money on this.
Right.
Is that where, am I right?
Yeah, I mean, the big part about it is, and the thing that I like about Flip the Pharmacy is you have people like Benjamin going out and talking to other pharmacies and sharing what they do. A lot of these have historically been kind of, a pharmacy school professor is going to go out and tell people, and, it'd be like me going out in the world and telling somebody how to run their business. I don't own a pharmacy, so I may know how to do it, but the credibility is not there. So a lot of the Flip the Pharmacy coaches are they've done it. They've succeeded in it, and now they're going out to show other people. And it's really about operational planning, right? They're getting more efficient so that they can do the operations and then go out and actually add the clinical services. Because if you just jump straight into care planning without knowing how to run your pharmacy, it just doesn't work. Mm-hmm. We've seen that over and over again.
Yeah. So, yeah, I mean, what's in it for you? Like, I think the ROI of this month's change package is a lot more apparent than the previous progressions, because we're telling people, hey, go look at the registry and then tell people they need to get their vaccines and then give them to them.
Right.
Like that directly increases your script count and your revenue.
Super tangible.
Right.
Yep.
That is a super easy see the value to the pharmacy. Right. And so, and like the other kinds of progressions and changes that they've done in the prior cohort, I'm in cohort 2, we just barely got started like last month. But the prior cohort spent a lot of time implementing medication synchronization in the pharmacies. And we'll be doing that in January as well. And that was some of the conversations that I had is like, let's set a goal to increase your sync patient count, right? Let's increase your prescription volume that goes through sync. And that has tangible benefits to the pharmacy as well, sure. Right? Yeah. You see substantially increased throughput of prescriptions, fewer phone calls coming in, fewer deliveries going out per prescription sold. Right. Like there are a multitude of benefits of MedSync. And so if these pharmacies get nothing but that they double their sync volume out of this, they will have benefited.
All right.
Right.
Gotcha.
And so, but like beyond that, each progression. So there's 4 progressions of different disease states, and it's 6 months focused on this next 6 months is diabetes immunizations. But what each progression, there's a month that's dedicated to let's build the business model for this, right? So go mechanic shop down the street and say, hey, do you think you would save money if your diabetic employees had better diabetes management? Go talk to the commercial carrier in your area and say, hey, you think you would save money if your patient's A1C was lower? Yeah, I think so. Do you think you'd save money if their blood pressure was under control? Yeah, I think so. How about pay us for it, right? And here, have a template contract for CPSN.
Cool.
Let's make this happen. It's a lot easier to have that conversation. Like you say, it's the ultimate white paper, right?
Right.
We can say, like, saying, hey, pay pharmacies to do this when you don't have any data is a hard conversation.
Sure.
But when you can say, look, this last month we gathered 30,000 blood pressures across our 2,500 network pharmacy, like, that's a much easier conversation to have,
Sure.
right? Because they're like, oh, yeah, I need blood pressure data to hit my HEDIS measures. Oh, yeah, I can sign that contract. How much?
All right.
And so, yeah, it's just exciting seeing. I mean, this frankly is the answer to the question you asked earlier of like, how do we get out of this doom and gloom? Well, it's building out this different payment model for pharmacy, right? We're still going to have the dispensing revenues. We're still going to have the dispensing business. That is the heart and soul of what the pharmacy is doing, and that's what drives the value with these kinds of interventions with Flip the Pharmacy.
Right.
Is that these people are like the classic example is someone who has diabetes and heart and high blood pressure and a mental health condition and all these things. They never take any of their meds, except they're also on Norco, and they come back every single month on day 30 for their Norco, right? They might be impossible for their health plan to find and
Right.
ask them about quitting smoking or whatever, but be in the pharmacy every 30 days on time, right at 9 o'clock in the morning, because they want to get their meds.
Right.
And so that is a patient that you can intervene with, where the health plan by themselves, they have no way to contact that member. If it's like a Medicaid MCO, this person doesn't have a phone number, they're homeless, right? But they're in your pharmacy every month to get their meds.
Right.
So for that kind of person, like that is the really easy example of where there's value in pharmacy and why we need to continue to have a viable dispensing business. Even if we shift to this business model, the dispensing itself still needs to be profitable.
Right.
Like we can't accept contracts that are paying it, $100 losses on any kind of brand name you fill, losing $100. Like that's unacceptable, because if we lose the ability to dispense, then we lose the ability to intervene with those kinds of patients.
Right. And that in itself is really, really smart. You're tying the ability to provide an actual physical, tangible good with that service. And that's what's different about pharmacy than it is about almost any other, health system or health provider outside of things like occupational therapy, right? You go to get a tangible benefit right there. But this is tied to an actual physical picked up thing that you can't skip.
What made you, or is it just you're super comfortable getting kind of in the mix on the social media side and really putting yourself out there and your opinions out there to be heard?
I'm just an outspoken guy. I don't know.
Good deal.
Yeah, I mean, I guess a lot of pharmacies are worried about ramifications for if they share their experience and they speak their truth, that the PBMs will come and retaliate against them.
Yeah.
And like there are clauses in your contract that say you can't disparage this PBM in the public. You can't, like, it says if you do that, they can get an injunction against you. Like you agree to that when you sign the contract. But I mean, my strategy has been to not, as a general rule, not target any particular PBM when I'm talking about these things.
Right. Yeah.
Because it's not that Caremark is evil or Optum is evil or Express Scripts or Prime or Castia or whoever other PBM is bad or evil or anything. It's not one PBM in particular. It's just the incentive structure built into the business model that's wrong, and it results in just all of these perverse incentives. And I don't know. I started doing this when I was in pharmacy school, and I had no I started being very vocal about these things in pharmacy school when, like, the worst case scenario is that, like, some PBM sends a cease and desist for saying that they did something bad. It wasn't going to go back and bite any kind of pharmacy. I mean, now the stakes are a little higher because, like, I'm affiliated with a pharmacy that my family owns. I feel like there's a lot more people willing to listen to my side than there are PBM lawyers out there to try and silence good faith pharmacists.
Right.
Like, I'm not trying to go screw over a health plan by dispensing these insanely high-priced drugs. I'm just trying to make a living by helping people with their medications and helping people with their health overall. And if the business model of a PBM gets in the way of that, I'm not going to be quiet about it, right? Because it's wrong. There should not be a, you must fill this prescription at specialty. That should not exist, frankly. Because it just means it, like, and honestly, I don't know. I have found in doing some reading that there is I am not afraid to say that the PBM industry is effectively a monopoly or an oligopsony, and to say that I think that there are Sherman Antitrust Act violations happening. They are protected because of entrenched interests, but I believe that the PBM industry is involved in substantial antitrust act violations. And in the last 4 years, just since I was in pharmacy school, there's been this dramatic shift in the overall, like, zeitgeist of America to be much more anti-monopoly than it was. And there's just a much more awareness that, like, having Facebook own with Google, like, 99% of online search advertising is not a good thing. And having Amazon control 90% of online sales is not a good thing. And having Caremark and Caremark own, like, the entire channel from owning Red Oak distribution to Caremark to CVS is not a good thing. Like, having these monopolistic entities across all industries, it's not just pharmacy, is harmful to the fabric of American life. And so that, like, seeing farmers and restaurateurs complain about Grubhub and about Tyson Foods makes me a lot more bold. Yeah. Right? Yeah. Because it's not just me. It's not just pharmacy. We're not, like, a lot of pharmacists say on social media, oh man, can you imagine another industry where someone else tells you your price and you just take it or leave it? And I'm like, chicken, book selling,
chicken farmers,
chicken. Yeah. I mean, it's not just us. And there's this growing movement across the whole country to rein in this monopolistic behavior by all flavors of companies. And I'm frankly, I'm really excited about
Good
it.
deal.
And it makes me a lot more confident.
It's funny that kind of explains a lot of the, like, I don't do anything on Facebook because, I don't want to give Zuckerberg any money. But, like seeing posts of yours like on LinkedIn, which is marginally better, but probably also still pretty evil. Like you come across as being like really authentic and like, here's what I believe and here's why I believe it. And I think that resonates with a lot of pharmacists who've been either afraid to speak up or haven't really been able to like articulate that and say, oh yeah, that's exactly what I feel like. There's that, those types of things drive it. And that kind of helps, I think, you connect with other pharmacists across the country and really have a point of view that feels I'm not going to say like the grapes of wrath kind of feel of, but it captures the whole, this is why I do what I do. And it irritates me that forces out of my control are doing things like that.
I'm going to not be quiet and say, look, we need to have Sherman antitrust investigations of all of these companies, right? And we need to remove the rules that the Department of Health and Human Services has put into place that allows these companies to engage in these anti small business tactics, right? Like rebates for brand name drugs shouldn't be a thing. They are a kickback.
Yeah.
It should be illegal under the anti-kickback statute. It's not, because there's a safe harbor in place.
Right.
Yeah, I mean, it's funny. We've been closely watching, all the PCMA stuff going with the Supreme Court, and like Arkansas and Ohio. Like, aside from being from Texas, I've never really been proud of Arkansas. But like the pictures of seeing the pharmacists crowd the state house to really push back, like literally hundreds of pharmacists there. It was like, okay, Arkansas is going to be the state that saves the practice of pharmacy.
Rutledge v. PCMA, let's just knock on wood here that it goes Rutledge's way, because otherwise I don't know that you can ever regulate a PBM in any meaningful way.
No.
So,
yeah, and then you have the other angle, right? You have the other angle of, okay, we'll just, we have some other folks standing their own up, right? You got, I guess things with Indy Health and Troy and those guys out there. It's kind of, the good part of that is they're not waiting on it, right? They're not waiting on Rutledge, and hopefully Rutledge works out. You're right. But hats off to those pharmacists that organized and said, we're going to be a part of this.
yeah.
Well, I think that is all the time we got today. Benjamin, thank you so much for being on. It was entertaining as always. I love that you're willing to give a hot take.
Yeah, no fear of the controversial statement on this one.
I love it. I wish I could even be like that. but Benjamin, again, thank you for what you're doing out there. Thanks for making us better. That's for sure. And I'm sure we'll be talking again soon.
Awesome.
All right. Well, thanks.
All right, Benjamin.
Thank you.
Thank you for listening to this Catalyst podcast. If you enjoyed this episode, please consider liking, subscribing, and/or following us. Give us a 5-star rating on Apple Podcasts to help us reach more amazing pharmacy people like you. Follow Pioneer X on your preferred social media platform for the latest up-to-date pharmacy news and content.